Welcome, everybody. Thank you for joining this Understanding More About Disability Progression and Multiple Sclerosis program. My name is Stuart Schlossman. I'm the president and founder of MS Views and News. Okay, this program is sponsored by Sanofi, or as some say, Sanofi. We did have two exhibitors there today. We had Novartis and we had TG Therapeutics, so I want to thank them. And I hope that you all in the room and online, please thank Sanofi for being our program sponsor. They very much deserve to be applauded, so I hope you can do this for them. Dr. Beaber is an MS neurologist. He has been specializing in MS neurology in the Los Angeles area for a number of years. He has an active presence on YouTube where he does a lot of videos. He has a book on Amazon, okay? It's called Resilience in the Fall of MS. There's an ebook version that's absolutely free. There's also a paperback version that you can purchase. Okay, Dr. Beaber, I had this idea to ask Dr. Beaber to speak at this program, and I'm so glad I did because he has brought this community a tremendous amount of information that I've never heard before. And if I haven't heard it, there's a good chance a lot of you haven't heard it either. Thank you, Dr. Beaber.
We're going to talk about multiple sclerosis and progression. Out of curiosity, has anyone in the room ever participated in a clinical trial in MS? Just show of hands. A few have, and I really appreciate that. Thank you for making the sacrifice to contribute to the science for future generations of people with MS. And the next question I want to ask is, has anyone had the experience of going to your neurologist and feeling that your MS is worse? Maybe it's more difficult to walk long distances, or maybe you're not as cognitively sharp, but you did not have a distinct relapse and you did not have any change on a recent conventional MRI scan. Has anyone experienced that? Show of hands. A lot of people have experienced that, and hopefully I can shed a little bit of light as to why that may happen. Now, I'm going to talk about a few specific pharmaceuticals, and just to be clear, the only real way to know for sure whether or not a certain medication is better for a certain person would be to do a randomized controlled trials. You have a group of people with the disease, you give half of them drug A randomly, half of them drug B randomly, follow them up over years and see how they do. And we just don't have a lot of data on some of the medications I'm going to mention. And so some of this is speculative, but the more information you have, the better, and you'll be a more informed person, can make better decisions for yourself. So how do people get worse with multiple sclerosis? Well, there are multiple ways. You could have an attack, a relapse, an exacerbation, a flare. This refers to having new neurological symptoms due to a focal area of inflammation in somewhere in the central nervous system. So this is an MRI scan of a 23-year-old woman who had pain in the left eye and vision loss in the left eye. You can see that the left optic nerve is white. This is optic neuritis, inflammation of the left optic nerve. Typically, symptoms come on fairly quickly over several days, and they may peak at a certain point and then improve. Relapses can be treated with steroids like intravenous methylprednisolone 1,000 milligrams daily for 3 to 5 days, or oral prednisone 1,250 milligrams daily for 3 to 5 days, and people may improve. Improvement from relapses is highly variable. Some people have 100% improvement, like they never had optic neuritis. Some people may have 90% improvement. Maybe their vision is 20/20, but if they exercise, they get a little blurry vision, or the color is not exactly the same, or there's a tiny gap in the vision, a scotoma. And of course, some people, unfortunately, may have significant long-term visual loss from optic neuritis, but most people make a pretty good recovery. Some other examples. This is a 28-year-old man who had double vision, and he had a neurological disorder called sixth nerve palsy. And what this means is that looking to the left side, his right eye moved to the left, but the left eye didn't move all the way to the left, and so he had double vision. And on his MRI, he has a lesion in the left pons affecting the nucleus of the nerve, the abducens nerve, that controls that muscle. And again, many people improve with steroids. This is an MRI of the cervical spine. You're looking at sagittal images like this, and the spinal cord should look dark But you can see at the C3 level, there's this bright lesion. This is transverse myelitis, inflammation of the spine, and it can cause symptoms such as numbness and weakness of the limbs. And some people have 100% recovery, but other people have residual symptoms. And so this is a little graphic. And on the y-axis, you're looking at the level of disability. And this refers to an EDSS scale I'll mention later. And on the x-axis is time. And so someone has baseline symptoms. And then with the relapse, there's a relatively rapid spike of worsening symptoms. And then there's improvement. But there may not be 100% improvement. So this gray area, the shaded area, refers to the residual symptoms. And this is RAW, relapse associated worsening. And I have patients who had a relapse 20 years ago and they still have residual symptoms related to that relapse. I have other patients who have had 10 attacks and they've essentially had a near complete recovery from all of them. It's highly variable from person to person. And so in the real world, the line could go all the way down or there could be virtually no improvement. But not all worsening of disability in MS comes from relapses. Some people with MS, they have a relapsing form of MS. They may have relapses over time. But many years later, 15, 20, 30 years later, they may stop having relapses. They may stop making new lesions on conventional MRI, but have a gradual worsening of symptoms. Someone may say, I used to be able to do a 5-mile walk, but now after a few miles, my legs get numb and weak and I have to take a rest. And then maybe later on, it would be difficult to even walk 1 mile or half a mile. And this could be very insidious. Sometimes it could be even misattributed to something else, like an knee injury. I have a bad knee or a bad hip, or even just aging or some other medical condition. Whereas in reality, it's subtle progression of the multiple sclerosis. And it's often recognized retrospectively. It's hard to say when it actually happens. Now, increasingly, it's been recognized that this could actually happen in anyone with multiple sclerosis. And many people with MS in the modern era are doing great. I have patients, I've seen them for 10 years. They're doing better than they were 10 years ago. But other people notice some subtle worsening, even younger people with relapsing MS with a relatively low amount of disability. I could look at them and maybe they walk okay, they seem fairly cognitively sharp, they're not having debilitating symptoms, they're still working, but they can tell that they are worse than they were years ago. It's subtle, it's gradual, but they can tell the difference. And increasingly, we're actually able to measure this. And so there's this idea that maybe we were biased where we were only recognizing progressive MS in people who were older and had more disability, because disability becomes more obvious when you're more disabled. But in reality, it may occur in anyone with MS, regardless of the so-called subtype of MS. And there's very strong evidence that relapsing MS and progressive MS are the same disease. So that's the concept of PIRA, progression independent of relapse activity. So here someone has had a relapse, they've recovered 100%, but later on they have a more gradual and insidious worsening of symptoms, and it's hard to say exactly when it started. Now, it turns out that most of the disability accumulation in MS is actually not relapse-associated worsening, it's actually PIRA. This is data from a clinical trial. These are the OPERA trials. This is actually 2 randomized trials in people with relapsing MS, and it studied the drug ocrelizumab, Ocrevus, versus Rebif. Ocrevus is a stronger medication that depletes B cells. Rebif is a beta interferon medication, and the trial showed that Ocrevus was more effective. Now, this is just looking at people who took the drug Rebif. So everyone here took the same medication. And it's looking at how they accumulated disability. So the top line, the black line, is total disability accumulation. Now, this is a metric where someone has worsening of their disability, And it wasn't just random fluctuation or temporary worsening, because on a follow-up examination, they were still worse, so that they actually progressed. It wasn't just measurement error or day-to-day fluctuation or relapse that they recovered from. So the black line is total disability accumulation, but relapse-associated worsening is the yellow line, only a small minority. Whereas PURA was the majority of the events. So out of 223 events of confirmed disability accumulation, 174, the clear majority, were PURA, and only 45 were relapse-associated worsening. And I don't know if anyone in the room has heard of Professor Gavin Giovannoni in London, Bart's in London. He has a famous MS blog. He says that relapses, new MRI lesions, they're not as important. This PURA, this slow, smoldering worsening, is sort of the real multiple sclerosis. And we care about relapses and new lesions on conventional MRI because they're dramatic and obvious. But what may actually be more important in the long run may actually be PURA. Now, that's not to say that relapses are not important, because they're actually associated with progression. This is a study looking at the number of relapses in the first 2 years of diagnosis and how long it took to develop progressive multiple sclerosis. Now, this isn't necessarily a great outcome as a trial, because it's really hard to say when someone actually has progressive MS, because it's often recognized retrospectively. And this is a very old study, so don't worry about the specific numbers. But in people who only had one attack in the first few years, it took about 20 years on average, median time, with a lot of variation from person to person, to have secondary progressive MS. Whereas people who had 3 or more attacks, it was only 15 years, so a 5-year difference. And we hope that by preventing relapses early in the disease, we're improving the prognosis of MS many, many years later, even if most of the disability isn't really related to symptoms directly related to that relapse. So how do we measure disability in people with MS? This is the EDSS scale, Expanded Disability Status Scale. And the scoring of this scale is very complicated. It's a 0 to 10 scale, 10 being the worst. And the way it works is at lower levels of disability, the score is based on functional system scores, such as symptoms of motor weakness, visual loss, walking problems. At the middle scores, 4.5 to 5.5, it's based on how far you can walk. And at higher scores, it's related to the use of mobility devices to walk and limitations in the upper extremities. So 0 to 2.5 would be considered lower disability, 3 to 4 would be moderate disability. And at 6, a cane is needed to walk 100 meters. And at 6.5, a walker or bilateral support, such as 2 canes, would be needed to walk all but shorter distances. Now, this has been used for a very long time, but it actually has a lot of problems in terms of studying MS because it's very biased in terms of what it measures. So, for example, someone who has lower disability, they could jump around between these numbers even within days. Whereas people with higher levels of disability, like someone with EDSS of 6.0, may stay the same for years, even if they're better or worse. For instance, let's say your balance is poor and you need to walk with a cane, but you could walk long distances. You could walk 5 miles. Let's say you get significantly worse and you could only walk relatively short distances with a cane, your EDSS would be 6.0. And it doesn't account for things like cognitive function, pain, fatigue, and things that we know are important in the day-to-day life of people with MS. They're just not really captured by this particular scale. So people have thought of the idea of using different measures called composite outcomes, where you look at different elements of different things in the nervous system and sort of add them together. So this is something called the MS functional composite, and it's starting to be used in modern MS trials. And I would be an advocate for this. I think that this would be a much better scale particularly for doing clinical trials in people who have more existing disability and in people who have progressive MS. And I think this could open up new treatments for people in that situation. And so it measures things like the time 25-foot walk, how long it takes to walk 25 feet. And a lot of people have probably had this done by their neurologist. Or the 9-hole peg test. This is a test where you use your hands to put pegs into holes. It's sort of a measure of upper extremity coordination. A cognitive test called the symbol digit modalities test. This is a test where there are symbols that have an association with numbers, and then you're given a list of symbols and you have to kind of match the numbers to the symbols. It's sort of a measure of processing speed. And something called low contrast visual acuity. This is like a Snellen eye chart, but it has a very light shade of gray. It's sort of more sensitive at picking up damage to the optic nerve and visual limitations. But there are also more modern measures we could use. One would be brain atrophy, shrinkage of the brain seen on MRI scans. It turns out everyone's brain is shrinking a little bit, even with normal aging. Someone without any neurological disease, roughly speaking, they're losing around 0.2 to 0.4% of their brain volume per year. And some people with MS can have accelerated brain atrophy. They could be losing 0.5 to 1% of brain volume per year. And this has been associated with disability outcomes and cognitive outcomes. And it's very difficult for me to eyeball a small difference, but with modern computer software, we can pick that up. Now, 25 feet is a pretty short distance. Most people want to walk much further than that. There's a test called the 6-minute walk test, which is how far you can walk over 6 minutes. You just take a stopwatch and see how far you can walk. If you could have walked 500 meters a few years ago, but only 300 meters now, you're probably getting a little bit worse, even though it's kind of difficult for your neurologist to actually measure it. There are also wearables, like if you have a Fitbit and you used to walk 10,000 steps a day and now you can only walk 7,500 steps a day, maybe that's a subtle sign that your MS is progressing a little bit, even though you may look the same to a casual observer. And there are also quality of life scales. People with MS, you can report how much pain do you have, how much fatigue do you have, how much difficulty do you have completing your day-to-day tasks, how much do the symptoms of MS affect your life. And actually, one of the most important measures is fatigue, which many people with MS rate as their worst symptom. Now, why are people getting worse? There's a lot of different theories as to why this may be the case. It may not be a single thing that's causing progression, but we believe that it has to do with something that's happening within the central nervous system. The reason we suspect this is it's very common for people to have progression of symptoms that previously existed. For instance, someone with MS could have transverse myelitis and have a lesion that affects the right side of the spinal cord and have some weakness in the right leg, but recover from it. But then many years later, if they develop progressive MS, they could have worsening of that symptom. Their right leg is getting slowly weaker over time, even if that lesion may look exactly the same on conventional MRI. So there's an idea, there's something happening in the nervous system that just may be difficult for us to see. And we have found that there may actually be inflammation within those old lesions that is called smoldering multiple sclerosis. And I'll get into the technicalities of the different immune cells in just a moment. But there are other theories also. It's been known that on autopsy, people with progressive MS may have this finding called meningeal B cell follicles. The meninges are the coverings of the brain. And that's not where MS damage is occurring. We care about the brain and the spinal cord and the optic nerve. But within these coverings, you can see these little clusters of B lymphocytes. These are cells involved in inflammation of MS, and it's a little bit unclear what they're doing there, but they're not reported in people with relapsing MS, and they are reported in progressive MS, so they may be related indirectly. There's this thought that metabolic failure may be part of the problem. When I was interviewing for fellowships in the early 2010s, I talked to Dr. Stephen Hauser at University of California, San Francisco, and he very confidently told me that progressive MS was caused by failure of the mitochondria, the little organelles within the neurons, the cells themselves, not the white matter, and that was causing progressive multiple sclerosis. And there is some evidence of that even today. There's also the idea that oxidative injury may be part of the problem. In organic chemistry, oxidation refers to chemical reactions that occur in carbon chains, which can be normal physiologic reactions, but they can also occur non-specifically, damaging carbon chains in things like cell membranes. There's also this idea that it may be related to Epstein-Barr virus. Probably many of you know that Epstein-Barr virus, the virus which causes mononucleosis, glandular fever, the kissing disease teenagers can get that can make you fatigued, is strongly associated with the risk of multiple sclerosis. It's a little bit unknown how it's involved in the ongoing progressive MS, but there's some evidence that this could be the case. And the last thing is actually just an aging process. This is the theory that maybe there's a certain amount of damage that occurs in multiple sclerosis, but if you're young and you're healthy, you can sort of compensate for that injury and function reasonably well. Whereas as you get older, due to changes that are happening in all people just related to aging, there could be a decreased ability to compensate for that injury. Now, that may seem to be highly pessimistic because we can't control our age. However, there's more and more research on this topic. Is it possible to modify the diet, take nutritional supplements, or even use certain medications that may reduce normal aging? And that could actually benefit everyone with every disease, but also people with multiple sclerosis. Now, let's start with smoldering multiple sclerosis. So as an analogy, if a multiple sclerosis flare or a new hot lesion on conventional MRI is like a hot fire that we can easily see, the fire goes out eventually, but it may not completely go out. There may be a little bit of heat there in these hot coals, and that's smoldering multiple sclerosis, a low level of inflammation that's occurring within the old lesions that have been there for years. And this has been reported in pathology studies, autopsy studies for many decades. We know that older people with progressive MS often have some degree of inflammation. Now, I won't go too much into the technicalities of immunology, but a few key points. So let's say you have hematopoietic stem cells in the bone marrow. They can differentiate into a lot of different types of white and red blood cells. On the right are the lymphocytes, the B and T cells. These are cells of the adaptive immunity. These are the cells that can recognize a specific antigen and target. For instance, I received the flu vaccine yesterday. Within the next few weeks, my lymphocytes will hopefully recognize those foreign antigens, and those cells that can target the flu will proliferate. And then later on, if I get exposed to the flu, I'm less likely to contract the illness or get a serious illness. And there's extremely strong evidence that these cells are important in the initiation of MS inflammation. There's a rare genetic disease called Bruton's agammaglobulinemia, where someone lacks B lymphocytes. They have 0 B cells from birth. And it's a bad disease because that person has an increased risk of infections throughout their life. However, to my knowledge, there are actually 0 people with that disease who have subsequently developed multiple sclerosis. So that disease seems to prevent multiple sclerosis. As far as I know, of course, there could be unreported cases. And so we know these cells are important in initiating inflammation in MS. However, a different type of cell can be found within old MS plaques, and those are cells of the innate immune system on the left-hand side. And some examples of these cells include neutrophils and macrophages. And there's a specialized macrophage within the brain that's called microglia. And these are cells that would not respond to the flu vaccine. They don't target a specific antigen. We don't think of them as being involved in initiating inflammation in MS, but they may be important in causing damage and causing progressive multiple sclerosis. So this is from an autopsy study in someone who presumably passed away for unrelated reasons, but lived with multiple sclerosis. And they looked at a lesion which appeared to be inactive on conventional MRI. And this is a stain for microglia. So they found these cells in the old plaques. Again, we think of lymphocytes, B and T cells, as causing MS, but these cells seem to be involved. We may be able to see that while you're still alive. So this is a conventional MRI, and it's a special type of sequence called SWI sequence. And here you can see there appears to be a dark rim at the edge of the lesion. And when people have done pathology studies, this seems to correlate with the presence of microglia in that area. And there are actually new proposed diagnostic criteria for MS, and they're actually incorporating the paramagnetic rim lesion into the diagnostic criteria. And reportedly, this lesion is 99.7% specific for MS, very rare in people without multiple sclerosis, though many people with MS do not have such lesions. This is another example of a paramagnetic rim lesion. And you could see on SWI sequence, you get a lot of blood vessels and things like this, but this is the edge of a multiple sclerosis plaque. Now, we may also be able to see this on PET scans. Obviously, PET scans are not used in routine clinical practice, but they could be helpful in clinical trials to develop new drugs. So this is a special type of PET scan which uses the tracer TSPO, and this is a metabolic marker of microglia. And this is from a 48-year-old woman with relapsing MS with an EDSS of 4, so moderate disability, who's had the disease for 12 years. And you can see it really lights up. There's a lot of microglial activity in the brain. This is a study that looked at healthy controls, people without MS, and you can see there's very little microglial activity. They used a different PET tracer, but again, this is a tracer for microglia and macrophages. So it's virtually absent in controls, but in relapsing MS, it's abundant, and in progressive MS, it's a little bit more abundant. You can see all this high signal throughout the brain. Now, this is a study in people with MS, many of whom were taking highly effective disease-modifying therapies. And you can see the little number here is the EDSS. So 7.5 would be a higher amount of disability, but some of them had very low disability, 1, 1.5, 1.5, 1. Many of these people were doing quite well, but on their PET scans, they still had signs of this microglial activity. You can see this is someone who has an EDSS of 1.5 and someone with 6.5, but they both have roughly equal evidence of microglial activity in the brain on these PET scans. And so unfortunately, this suggests that our highly effective disease-modifying therapies, medications that are very good at stopping relapses, very good at stopping new MRI lesions, they don't seem to be that effective at stopping this microglial activity. And this is a study that actually looks at normal appearing white matter. So you do an MRI scan, you see T2 bright white matter lesions, but there's also part of the brain that looks normal. And they compared a 42-year-old man who does not have MS versus a 40-year-old man with secondary progressive MS. And I know it's difficult to see on this slide, but they report they can detect differences even in parts of the brain that appear to be unaffected by MS. So this may be a global process occurring throughout the brain, even in areas that look normal when we're looking at just a regular MRI scan. Now, this is a schematic looking at a smoldering multiple sclerosis plaque. So MS is a perivenular disease. The lesions tend to occur around the postcapillary venules. So you have arteries, arterioles, smaller and smaller arterioles, then capillaries, and then those capillaries collect into veins the MS plaques tend to form around those veins, probably because that's where the immune system can extravasate into the central nervous system. And so you have this lesion and you have a lot of white blood cells and you have lymphocytes. So CD20 positive cells are the B cells, CD8 positive cells are the killer T cells. However, at the edge of the lesion, what has been reported on autopsy studies is these microglia, and they may be causing the lesion to have increasing injury or even to slowly expand. Sometimes we can see a lesion on conventional MRI get slightly bigger on subsequent scans, or even if it looks the same size, there may be more injury occurring there. Now, that's not to say that regular T2 lesions don't matter. This is looking at a study looking at the correlation between just normal T2 lesions and microglial activation as measured by PET scans. And they looked at different areas of the brain, the normal appearing white matter, the thalamus, and there's a correlation. So having more lesions in the brain is definitely bad. There is some correlation with this microglial activity. And hopefully, if we're preventing new lesions, we're at least doing something to prevent this microglial activation, but it doesn't seem to be enough, at least not in all people with MS. Now, the next question is what we can do about it. So there are novel medications that are being studied that may better address this problem. Of course, there are many people with MS who are doing great, who are living wonderful lives, who have a relatively low level of disability. But we unfortunately know that these medications don't work for everyone, so we must do better over time. And this is somewhat speculative, but these are some examples of medications that could be more effective. And one group is medications called BTKIs, or Bruton's tyrosine kinase inhibitors. So Bruton's tyrosine kinase is an intracellular enzyme that's within different types of white blood cells. And so it is involved in the proliferation of white blood cells, the maturation of white blood cells, and it's present in lymphocytes like B cells, but it is also present in macrophages and microglia. So in theory, this type of drug could do something that a B cell depleting drug like Ocrevus, rituximab, Briumvi, Kesimpta maybe could not do. And it could be more effective for some people with multiple sclerosis. And some examples include tolebrutinib, fenebrutinib, and evobrutinib. None of these drugs are currently available or FDA approved, but some of them are quite advanced and could be available relatively soon within the next few years. Another interesting medication is firalimab. This has actually been studied as an intranasal spray, and it's a medication that targets CD3, which is the marker of T cells. Now, if you killed all of your T cells, the risk would be extraordinary. There would be a very high rate of infection. But this drug does not kill all of the T cells. It modulates the effect of T cells. And it's a little bit unclear how this would affect microglia because they're very different from T cells. But there's actually research that it does reduce this evidence of microglial activity on PET scans. Another interesting drug is vidofludimus calcium. Now, this drug works on the enzyme DHODH, which is dihydroorotate dehydrogenase. And this is similar to the MS drug tolebrutinib or Aubagio, or the rheumatoid arthritis drug Arava. And this is a modestly effective class of drugs for multiple sclerosis. However, this specific compound has another effect. It activates something called NER1, and it's a little bit unclear how this could affect people with multiple sclerosis, but it's been reported to reduce expression of certain genes in the microglia. Now, this is highly speculative, very preliminary, no real data on it. Another interesting drug is frexalimab. This targets CD40 ligand, and this is the co-stimulatory signal. So let's say you have an antigen-presenting cell, something that takes a foreign protein and shows it to your T cells. There is another cell surface protein that's involved in stimulation of that T cell. However, CD40L is also present on macrophages and microglia, so it's thought in theory it could have some effects on those cells. So I'll show a little bit of data. This is for the drug Firalimab, and this is a single person with multiple sclerosis, and they reportedly have secondary progressive MS, and they were on a B cell depleting drug and getting worse over time. And they started the drug Firalimab, and they stabilized only over a 6-month period. And of course, many people could be stable for 6 months, so it doesn't mean too much. But they did PET scans, and they found that over a 6-month period, there was a reduction in microglial activity as adjudicated by TSPO PET by 38%. So it seems to have some biological effect. There was a second study with 10 individuals taking this drug, just an open label trial, not a randomized trial with a control group, and they recapitulated the same finding that there was reduction in this signal on PET scans. Just a before-after study. This would need to be confirmed in a randomized trial, and we would need to see, does this actually translate into a clinical benefit of the drug? This is actually a study in Alzheimer's disease. It turns out that Alzheimer's disease has an inflammatory component to it, and that's how inflammatory drugs could benefit people with Alzheimer's disease. And this is just a single person before Firalimab and after Firalimab, and there's a significant reduction in microglial activity. Does this actually benefit people with Alzheimer's disease? We don't know. This is a study on the drug tolebrutinib. This is one of the Bruton's tyrosine kinase inhibitors, and this is from a clinical trial called the Hercules trial in people with secondary progressive multiple sclerosis who did not have recent relapses. And we have less options, and so this is very important. And the primary endpoint was confirmed disability progression on the y-axis, which again is someone who has gotten worse in terms of their EDSS score, and on a subsequent evaluation, they still did not improve. And it's a comparison against placebo, the green line, and you can see there was less disability progression in people who got the drug. Now, the difference was 31%. It was not an enormous benefit, but it did reduce disability progression. There is a risk of liver injury with this drug. And there's another clinical trial called the Perseus trial, which is nearly completed in people with primary progressive MS. And so we'll see if the same result is found that would essentially confirm that this is a real effect. One interesting thing about this trial is they reported if you did a subgroup analysis and looked at people who on their MRI scans had these dark rim lesions, the paramagnetic rim lesions, they seem to have a better benefit with the drug. So it's possible that in the future, we may be able to personalize medicine in people with MS, give someone a medication more likely to benefit them based on their specific MRI features. And by the way, this is conventional MRI SWI sequence. So if you've had an MRI scan, you may be able to see if you've had a paramagnetic rim lesion, which hasn't been particularly useful information, but it may be useful information in the future. This is an ongoing clinical trial called the FENtrepid trial. This is a randomized trial in people with primary progressive multiple sclerosis comparing two drugs. One is ocrelizumab, Ocrevus, a drug that depletes B lymphocytes, more of a traditional MS drug, you could say. The other is fenebrutinib, a Bruton's tyrosine kinase inhibitor. And so we'll see, is fenebrutinib actually more effective, or is it equally effective or less effective? We'll have to wait for the results, but this is certainly a clinical trial to keep your eye on. Now let's move on to another topic. This is the B cell follicles. This is an autopsy, and you can see a CD20 stain, which stains B lymphocytes in the meninges, the covering of the brain, and there's this huge cluster of B cells. And it's a little unclear what they do. Again, this is not where MS injury is occurring. Your meninges don't control your vision or your cognitive function, but it's thought that this cluster of cells could have an immune effect on other cells in the brain and somehow contribute to progression, because we don't really see this in relapsing MS. So one theoretical treatment is intrathecal B cell depleters. And there was actually someone at Johns Hopkins who was studying intrathecal rituximab. And my understanding is that it was thought to be not effective. So right now, we don't know how to address this particular problem. But perhaps if we could come up with a drug that actually gets rid of these B cell follicles, that actually gets to the region, because B cell depleters tend to be large molecules that would not necessarily enter this area, it could actually be effective. What about oxidative injury? There are a lot of theoretical reasons to believe that this is important. For instance, animal models of multiple sclerosis, experimental autoimmune encephalomyelitis, we know that those rats have evidence of oxidative injury in their brains. We know that in human autopsy studies, if you look at the myelin of people with MS, it can be oxidized. The phospholipids, the cell membrane components, the lipids within myelin can be oxidized. We know that there are dangerous reactive oxygen species within multiple sclerosis plaques, and there's some impairment of certain protective enzymes that are supposed to prevent oxidative damage, such as glutathione peroxidase and superoxide dismutase. And we know that mitochondrial failure within the cell, within the neuron, can occur. Now, it's sort of unknown how we can affect this. One theory is diet may play a role. Maybe if you had a certain diet, you could have a more robust metabolic system, be more resistant to oxidative injury, and that could benefit people with multiple sclerosis. Or to take certain nutritional supplements that may help with the function of the mitochondria or prevent oxidative injury. There's also an interesting investigational drug called CNM-Au8. This is a very weird pharmaceutical. What it is just gold, literally the element gold, where gold is manufactured into tiny microparticles that are so small they can actually enter the cell. And because of the chemical properties of gold, it may actually somehow support the function of metabolism within the cell. It may facilitate biochemical reactions in the cell and, in theory, overcome some of the metabolic limitations that could occur in people with MS. This is very early on. We don't know if this works or not. Now, going back to nutrition, just to show one example in research on nutrition, this is a study comparing two diets. Many people have probably heard of Dr. Terry Walls. She's a doctor who says that her own secondary progressive multiple sclerosis improved after keeping a paleo-type diet, taking nutritional supplements, and doing other things like specialized exercise. And so she's involved in doing clinical trials on her diet. Many of you people who are a little bit older may have heard of Roy Swank, who passed away in the 1990s. He's from Oregon Health Sciences University, and he believed that a low saturated fat diet could benefit people from multiple sclerosis. There's evidence from an epidemiologic standpoint that in countries where there's higher dairy and saturated fat consumption, there are lower rates of multiple sclerosis. And they compared the two diets in a randomized trial, and they measured the 6-minute walk test, how far you could walk in 6 minutes. The very meaningful outcome. A lot of people with MS complain that it's difficult to walk long distances, and everyone improved in both diets, and there were better results in the Walls diet. So I wouldn't say there's necessarily definitive evidence for a specific diet, but there is some evidence that diet could make a difference. What about Epstein-Barr virus? Now, many of you know that Epstein-Barr virus is linked to risk of multiple sclerosis. We know that people who had mono, the actual symptomatic illness, have double the rate of getting multiple sclerosis. We believe that if you encounter the virus a little bit later, like as a teenager, that may be associated with an increased rate of getting multiple sclerosis. And we know that if you've never encountered the virus, your risk of getting MS is extremely low. And this is a study that got a lot of press from the United States military, and it looked at people and their antibody levels against the virus. So if you have antibodies against the virus, you have previously been exposed to it. And on the left is the comparison group, people who have never had Epstein-Barr virus, which is Unfortunately, only 5% of the general population. So even if you don't have multiple sclerosis, you probably had Epstein-Barr virus infection. And then the right side are people who tested positive from the beginning of the study, or people who seroconverted. In other words, they were initially negative, but later tested positive. And these right two groups had a roughly 30-fold increased rate of getting multiple sclerosis. And in fact, there was only one person in the entire study who tested negative for the antibodies and still got multiple sclerosis. And every laboratory test has some error, and biology is just not perfect. So it's almost as though Epstein-Barr virus infection is a necessary but not sufficient reason to get multiple sclerosis. Now, does this just influence your risk of getting MS, or could it change the prognosis of MS? This is actually looking at a pathology slide in an active multiple sclerosis plaque staining for EBNA2. This is an Epstein-Barr virus protein, and it's abundant. It's within multiple sclerosis plaques. So when you get EBV infection, it infects a lot of different tissues. It infects cells of the epithelium of the nasopharynx, and that's why people can get cold-like symptoms. But it can also affect the B cells, the B lymphocytes. And there's some evidence that it can get into those cells and stay there chronically, and may even change the properties of those cells. It may make them less sensitive to regulation by T cells and may immortalize them. It may cause those cells to last longer than they should normally last. And you can see Epstein-Barr virus protein is abundant within the lesion. Is this an incidental finding? Or so there's no current known treatment for Epstein-Barr virus. And most people recover, but a small minority of those people will go on to get multiple sclerosis. This is another slide looking at the meninges. So I mentioned those meningeal follicles. Well, it turns out they have evidence of Epstein-Barr virus as well. This is a stain for Epstein-Barr virus messenger RNA, and it's abundant within those B cell follicles. So in theory, maybe Epstein-Barr virus is infecting those B cells, causing them to become activated, cluster, and drive some of the inflammation in MS. So what could we do about it? An audience member said, there's nothing proven to do about it. Well, in theory, one solution would be vaccination. Now, the sort of bad news is that over 50% of the population is actually infected with EBV prior to age 6. And so if we were going to vaccinate, we would have to vaccinate very early in life, or it may not be effective. Also, that vaccination would have to be highly effective, because if you lost your immunity from vaccination and ended up getting EBV later on, that could potentially increase your chance of getting multiple sclerosis. But if you had an effective vaccination that you could give early in life prior to contracting Epstein-Barr virus, maybe you could prevent or eradicate multiple sclerosis. And there's some research on this topic. Of course, we'll have to wait a long time to see who ends up developing multiple sclerosis. What about antiviral treatments? If we gave someone a medication that would have activity against Epstein-Barr virus, even though it doesn't seem to be causing overt symptoms, could that be beneficial in people with multiple sclerosis? And there's actually another virus called human endogenous retrovirus W, which is associated with multiple sclerosis. And because that virus is a retrovirus, it's thought that medications that treat other retroviruses, such as HIV, could be beneficial. This is also something which has been studied. The other thing is using an immunotherapeutic, not a drug like an antiviral, but using immune cells to target the virus. And there was actually a pharmaceutical called ATA188, which is an immunotherapeutic targeting Epstein-Barr virus. And unfortunately, in a clinical trial, it was unsuccessful in treating MS, but maybe a similar medication with some technical differences that could be more effective given over a long enough period of time could be beneficial. And as I said, a lot of this is theoretical. I think many of these things have potential to help people with MS. So that's it for my presentation. I'm happy to take some questions.
So thank you very much. Let's all give Dr. Beaber a round of applause. Going to the top of things. A lot of people have asked about smoking and multiple sclerosis. What can you tell them about this, please?
So there's evidence that people who smoke have a slightly increased risk of getting multiple sclerosis. And there's also evidence that people with MS who smoke have a slightly worse prognosis. The effect is not a large effect, but there definitely is a proven correlation in many trials. And so obviously, if you have MS, it's advised to quit smoking. And the most successful method used to quit smoking, the majority of people who successfully quit smoking use the method of just quitting. Just pick a quit date. After this date, I'm not going to smoke cigarettes and just quit. Of course, if that does not work, there are many other methods like the patch, for instance. But that is definitely an important part of the management of MS.
When you want people to test out the new drugs, you give them pull this one and you give them this one and they take a survey. How many people do you have that last and take the test the whole time? It's usually 2 to 3 years.
Typically, a clinical trial has around 400 people in each group, like the control group and the treatment group. And a typical MS clinical trial is 2 years. That's a phase 3 trial. Some of the more preliminary trials, where they're just trying to look at safety of the medication or preliminary markers like PET scans, may only be 1 year. But the phase 3 trial typically is about 2 years. It varies on the trial, but the people in the clinical trial, the people running the trial, want it to be as high as possible. They don't want to have any bias of people quitting the trial. So when you sign up, they want you to be highly interested to stick it out through the end.
Is there anything linked to MS and Parkinson's? Or
To my knowledge, there's not a known association between risk of MS and Parkinson's disease. Occasionally, people with MS can have symptoms similar to Parkinson's disease. Some people with MS can have a gait that looks similar to someone with Parkinson's disease, but it's sort of coincidental.
Back to the smoking, is it tobacco, marijuana, or
So there's no evidence that other drugs worsen multiple sclerosis. So there's no evidence that the drug marijuana worsens multiple sclerosis. Now, that may be true for tobacco also. It may be more inhaling burned smoke causes a pro-inflammatory response rather than the actual drug tobacco. So there could be some potential risk with smoking marijuana if just inflammation from inhaling smoke is harmful. But there's no evidence that the drug marijuana worsens MS. The same is true with alcohol. Numerous studies suggest that consumption of alcohol is not associated with an increased risk of MS.
Thank you. All right, let's go to a few online questions. The first one, it's not political, but a person wants to know how cutbacks from the current administration affecting clinical trials in medicine. How will this affect what is happening in the United States for clinical trials about multiple sclerosis?
I don't see how that's not political, but in terms of getting funding through the NIH, if there's less funding, it's going to be a little bit more difficult to do those clinical trials. So there's certain types of clinical trials where maybe a drug is already FDA approved, is used for other conditions. There's no money in it, or something like a nutritional supplement or diet. There's no money in it. It's very hard for a pharmaceutical company to justify doing that type of study. So you sort of need independent funding. For something like tolebrutinib, pharmaceutical companies can make a profit on it. I think there'll always be money for that. It's more these other questions, like, for instance, can people take certain medications for MS less often to reduce the effect of getting infections and still be effective? I think we need independent funding from that type of research. And if it's not coming from the NIH, it may have to come from other sources like private donors who really care about MS research.
Okay, thank you. Next one. How does a person tell the difference between having just a bad day when they wake up, or if things are MS related, even during the day? Is there a distinct difference?
Sometimes there is not a distinct difference. It's very common for people with MS, even if they're stable, to have a lot of fluctuation of symptoms. Sometimes there could be an obvious cause of this, like sleep deprivation or an infection, urinary tract infection, dehydration, stress, heat. And sometimes there isn't an obvious cause. I think sometimes the onset of a multiple sclerosis flare could be very similar to day-to-day fluctuation, and it may take a few days to figure that out.
Thank you. Next, the next one is concerning, can you talk a little bit about PPMS progression versus other forms of MS?
So my personal opinion is that all forms of multiple sclerosis are the same. And I think that there's no difference between primary progressive MS and secondary progressive MS. For example, I have a patient who I saw in their mid 60s and they had progressive walking difficulty. And they had MRI scans and spinal tap findings consistent with multiple sclerosis. And I asked them, have you ever had any neurological symptoms before, like vision changes or numbness? And they said no. And so I diagnosed them with primary progressive MS. But later on, they told me, as sort of an off the cuff comment, when I was 30, I had optic neuritis. And so this person actually had secondary progressive MS. They just had a very unusual 30+ year remission, which is strange, but can happen in MS. And so the reality is, people don't have a perfect ability to recount all of the symptoms they've had throughout their life. And also, sometimes it's hard to know if a prior symptom was actually MS related. Was that tingling in your hand 10 years ago carpal tunnel syndrome or your first MS flare? It's hard to know. There's a lot of evidence in terms of MRI scans, and the rate of progression in MS is the same in SPMS and PPMS, roughly speaking. So in my opinion, it's all the same. It's just MS progression. Sometimes it can be very slow and mild over many years, sometimes a little bit more rapid, sometimes affecting different symptoms, but I think it's the same underlying concept.
We have a question in the audience.
Yeah. Yes. I was wondering, do you guys do any testing on like cognitive progression in MS? Because it seems like me noticing that maybe my walk and everything might be good, but my thinking is kind of off. I do A as it's supposed to be, and then I know that if I go to say a word or something, some other word will come out. It's like say bat, but then I might say dog, something like that. So is there any research or data on the cognitive progression of MS?
So people are increasingly recognizing that that is an important outcome. So as I mentioned kind of earlier in the presentation, if someone had significant walking problems, having a change in cognitive function would not change the EDSS score. And that becomes a problem if we're trying to measure it and use that as an outcome in a clinical trial. And that's kind of why the more modern metrics, the composite outcomes, include cognitive function. So I showed you the symbol digit modalities test, which is a really good test for processing speed. There's some other cognitive outcomes. One of them that's used is called the PACE-AT, the Paced Auditory Serial Addition Test. This is where you hear a series of numbers like 1 and 2, and then you add them together and say 3, and then you hear the next number 5, and you have to ignore what you said and add it to the 2 and say 7. And that seems to be a very sensitive measure of cognitive function. And of course, it's possible to see a neuropsychologist and get a battery of tests that measure cognitive function and look at different domains like short-term memory, processing speed, fund of knowledge. And so that's being increasingly recognized as an important outcome in MS. And many people with MS, they walk okay, but maybe they're disabled because of their cognitive symptoms. And so I think that's very important. And it is possible to measure it.
I have a question. Is like slurred speech like one of the symptoms? Because I get that you sound drunk, and I'm like, well, not yet, but maybe later, Or I've heard people say, oh, you sound okay, because, you know, I've heard slurred speech is one of the symptoms. Is that correct?
That is correct. Slurred speech is a well-known symptom of MS.
Are the studies of the microglia also using MSers with more spinal lesions than the brain?
So most of the data on PET scans of the brain are looking at the brain. It's very difficult to detect it in a living person in the spine, but pathology studies do also show activation of the innate immune system in the spine based on autopsy studies. I'm not sure of the technical limitations, but I think that's a little harder to detect on these PET scans in the spine in living people with MS. But I do think that inflammation is there in the spine as well.
I wanted to ask, with brain fog and those type of things happening, as you age, you progress as well. So how do you know the difference between the two? How can you truly tell it's MS related or maybe just age related?
So, my experience personally is I think a lot of things that people with MS notice is related to multiple sclerosis. Now, if someone is 80 years old and says, over the last 10 years, I've noticed a very slight change in cognitive function, of course, that could be due to aging. But my general opinion is a lot of the times when someone notes a symptom like that, it is related to MS. I mean, I notice some decline in cognitive function just with aging. Hopefully I don't have any neurological disease causing that. But, when someone's complaining of more significant things, difficult processing speed or difficulty multitasking that's affecting their day-to-day life, my opinion is most of the time it is related to MS.
Right, thank you. How does the medical field like yourself explain to inform patients of how they can tell family and friends of their primary progressive MS status?
Well, the reality is, I think most people in the general population know very little about MS. And I think the little that they know is mostly what they see in terms of celebrities reporting their symptoms. And so I think it can be very frustrating with people with MS to do this, but probably just try to explain to them not necessarily what MS is in general, but just how it affects you. Try to describe the symptoms you have and how it's affecting your life. I think it's very hard for someone who barely knows anything about MS to learn much about it, at least in a short period of time. But I think you should be able to explain to them your own symptoms. And that's probably what's most important if you're talking to friends and family members.
Okay, so for those MS patients who know a lot about multiple sclerosis, how would they go about explaining to their family why they're worsening to the degree that they might be worsening if they have a progressive form of MS?
Well, I think that you could explain that, try to, in a very basic terms, try to explain what may be causing some of the progression. That there could be a slow inflammation occurring in different parts of the nervous system, making the function of that type part of the nervous system less effective, or changes in the metabolism. And just to kind of explain that this is a common symptom of multiple sclerosis, that people could have slow progression and that there's a lot of variation from person to person. And I think could be frustrating to someone with MS, where some people may have very minimal symptoms and be stable, whereas you may have progression. And I think you just have to explain that there's a wide variation and to explain to them what your symptoms are and how they feel and how they affect your life.
Thank you for that. Next, several people are asking about the BTK inhibitor. They think that some think that it's being used in conjunction with a current DMT. Can you please explain how this will be used?
So it is possible that we could give multiple medications to someone at the same time. And this is commonly done with other autoimmune diseases like rheumatoid arthritis. But it's not really usually done in multiple sclerosis. In the past, there was a randomized trial called the CombiRx trial, which looked at the drugs Copaxone and Avonex, and then looked at, can you take them together? Will it make it more effective? And it turned out that it didn't work, that taking both Avonex and Copaxone together was not more effective than just taking Copaxone. And so that's why we don't recommend that. But because something like a B cell depleter and a Bruton's tyrosine kinase inhibitor work in different ways and maybe both important in treating MS, maybe you could take them together. The problem with that is that you may have a high risk. So we know that B cell depleters have a risk of causing infections, and to some extent, Bruton's tyrosine kinase inhibitors have a risk of causing infections, and they also have a risk of liver injury. And we just don't know how safe they would be to take together. But probably, if both are effective, maybe someone will eventually study them together and we can see if it's effective or safe. But we just don't have any knowledge of that right now.
Thank you. Going to age related, there are people that are asking from different age groups over 60. is it worth them getting onto a DMT now if they've never used one?
So this is a controversial topic. A lot of the clinical trials in people with MS have age cutoffs. So a lot of clinical trials have an age cutoff of 55. And this is very unfortunate because about a third of people with MS are over age 55. And so we have less data on people who are older. The other concern is some of the medications, especially medications that weaken the immune system and can cause infections, the risk of getting those infections may be higher if you're older and have other medical conditions. So we don't necessarily know the answer to that question, but I think that most people would recommend disease-modifying therapy to people who are recently diagnosed with MS, especially if they had recent relapses, recent MRI activity. I think that's widely accepted. We may have more data on this in the future. There is a neurologist, Klaus Schmeier, over in London, who's doing a trial called the Chariot MS trial, studying the drug cladribine, and they actually have no age cutoff. And I believe they have a patient who's 80 years old. And so it's important to know the safety and efficacy of the medications in everyone with MS.
Thank you. All right, going to the other side of the coin. For those that are under 60 years of age, there are people on here that are asking, if I don't do a DMT, will I worsen? There are others asking, is it probable that my medication might begin to fail me? There are other people that are asking about if they decide to wait until they're 60 to stop, is that a good idea? So if you could answer all the above, that will take care of half the list.
To answer the first question, there's some evidence that medications may be more effective in people who are younger or who've had MS for less time and are less disabled. So generally speaking, it's not recommended to delay treatment. This is very counterintuitive because a lot of people for a lot of different medical conditions would say, well, my symptoms aren't that bad. I don't want to take the risk of a medication right now, and I'd rather wait until I really need it. But these medications are preventative medications. They don't grow nerve tissue. They don't cause remyelination. They only prevent inflammation and new damage to the nervous system. So someone who has a low amount of disability, who's early in their disease course, is a great candidate for a stronger medication, often in my personal opinion. And of course, different neurologists may have different opinions, and every individual may have a different risk tolerance. I have patients who they don't want to take any medication that has any risk of weakening the immune system or has any chance of causing infections, particularly when COVID-19 was bad. And so that's an individual decision as well. In terms of stopping treatment as people get older, we just don't have that much data on the topic. So it's hard for me to answer that in an evidence-based way. I think if you talk to different doctors, they would have different opinions. I mean, certainly I would have reservation about recommending a medication that has a high risk in someone who's older and has a lot of medical conditions, and I think would have a high chance of getting complications.
Great, thank you. For those that are having relapses, what do you recommend that they do first?
Well, the standard treatment of a relapse is getting steroids. And so typically someone would try to get an appointment with a neurologist. And, if they have clear symptoms of a relapse, the standard treatments are high doses of steroids. Steroids don't penetrate into the central nervous system. So very high doses are used, much higher than what is used to treat something like asthma or poison ivy. And typical courses of steroids are IV methylprednisolone or solumedrol daily for 3 to 5 days. There's actually a study in Europe suggesting that the drug prednisone, oral prednisone, is equally effective, and the equivalent dose is 1,250 milligrams, which is 25 50 milligram tablets. And, if someone has a bad relapse and they're desperate, they can't get a hold of their neurologist, some people will just go to the emergency room, which is perfectly okay.
Great, thank you. All right, next, can the COVID booster cause fatigue in MS patients and in general?
So in general, if someone has MS, any sort of insult to the body can cause a temporary worsening of symptoms. And so if you get any vaccine and you get, particularly if you get fever or other bad side effects, it's quite common to cause a worsening of symptoms known as a multiple sclerosis pseudo-exacerbation. We believe that this is not causing new damage to the nervous system. It's not like there's new injury to the brain or the spinal cord, but it's causing sort of a weakening of the body so that it cannot compensate for the existing injury. And unfortunately, it is fairly common for people to get some temporary worsening of MS symptoms if they get a reaction to a vaccine. But we don't think it worsens the underlying disease.
Thank you. There are many people using high-efficacy MS medications, and several are saying that they believe that they're relapsing and that their doctors don't necessarily want to take them off the medication that they're currently using. When is it time to change to another high-efficacy medication?
So the whole point of taking disease-modifying therapy isn't to feel better or treat symptoms or have less pain or less fatigue. It's to prevent new damage to the nervous system. So to prevent new attacks or lesions on the MRI or worsening disability. So if someone's having relapses, the medication is not working, and you have to have a discussion, with your neurologist. Now, if you're already on a high efficacy medicine but having progression, there's sort of less evidence about what to do. And certainly some people will have a slow progression in the absence of relapses and new MRI lesions pura, even despite taking these medications. And it's unknown. We don't have proof of the right thing to do, but many people will change medications. And one thing I should note is even good medications don't work in everyone all the time. That's just the reality. No medicine is perfect. Like, for instance, people taking natalizumab or Tysabri, it's possible to have anti-drug antibodies, so the drug is just ineffective in a particular person. And so even if a drug is good, it may not be working for you.
Is there a pipeline medication for an oral med for people with PPMS?
Yes, many of like the Bruton tyrosine kinase inhibitors are oral meds. Firalimab is being studied as an intranasal formulation, but there's also a pill formulation.
Okay, thank you. Next, can you give more information, please, on remyelination and what is happening?
So remyelination is something that can happen spontaneously all the time. And many people with MS can have very severe relapses and make major, major improvements. And we think a lot of that improvement is one, reduction in inflammation, so the tissue could function, but also remyelination. And so we know that often the axons, the underlying nerve fibers, are somewhat spared in many people with multiple sclerosis. And so, but there can be a lot of injury to that fatty sheath, the myelin, but it has a lot of regenerative capacity. And we think that's a lot of how recovery from relapses can occur. On conventional MRI scans, if a lesion is bright on T2 sequences, but it is not dark on T1 sequences, it looks normal on T1 sequences, this is called a shadow plaque. And when people have done autopsy studies, that seems to correlate with remyelination. So this is something that seems to happen normally. And there was actually a famous study done by the neuropathologist Bruce Trapp, where he looked at people who were older, who had progressive MS, many of whom had significant disability. And we know that the oligodendrocyte precursor cells, the cells that can turn into oligodendrocytes, the myelinating cells of the central nervous system, are there within the lesions, and there may be a failure of remyelination. So that may be part of the pathogenesis of progressive MS. Now, the next question you could ask is, can we do something about it? Is there a certain lifestyle, a certain diet that would somehow facilitate that remyelination? It's sort of unproven. There is an investigational drug called PIPE 307, which has some evidence as a potential remyelinating agent. It's in early clinical trials right now.
Thank you. All right, next good question. So for many who see non-MS professional experts, for the many who are seeing community neurologists, for those many people that complain to their doctors that they feel that they are getting worse and that their doctor then orders an MRI and the MRI does not show worsening, as you know, is called pura. but how do they actually communicate better with this neurologist to get them to understand that maybe there is something underlying happening and don't just go by the clinical whatever's being seen?
So, all neurologists are different. There are some general neurologists who don't specialize in MS who are very skilled and knowledgeable about treating MS. I do a lot of general neurology. I treat people with Parkinson's disease, epilepsy, migraine, and other things, even though I'm not a specialist in that area. But the ability of any individual clinician in MS is going to vary significantly. And I would hope that most neurologists in general, regardless of their specialty, would understand the concept of multiple sclerosis progression, that some people get worse in the absence of a relapse. I think at this point, it's widely known, and I think you should be able to explain that to your neurologist. But if you're very dissatisfied, you feel they're not listening to you, understanding you, you can always get a second opinion. Luckily, we're in Los Angeles, where there are a lot of neurologists out there, and hopefully you're able to get a second opinion with someone you think is more qualified.
Great, thank you. The next one is, have PET scans ever been used while doing a diagnosis or follow up to something else happening with MS?
So PET scans haven't been used in routine clinical practice. I think that conventional MRI would be more helpful for the diagnosis of multiple sclerosis. But I do think if this sort of theory about smoldering MS and response to certain medications is proven, it's possible, for instance, like if we could prove that a drug like a B cell depleter or natalizumab is not going to work in someone with extensive microglial activation on PET scan, but maybe another class of medications like faricimab or a BTKI would be more effective. If that could be proven, which in my opinion is currently not proven, then potentially it could be used in clinical practice. But right now, they're not, widely available.
Thank you. What are some of the reasons to have a pseudo relapse?
Some of the most common reasons to have a pseudoexacerbation would be infection, like a urinary tract infection, upper respiratory tract infection, heat, particularly during the hot summer, people who are out exercising in the heat. And some people can have quite a profound worsening of symptoms, sometimes stress or sleep deprivation, and sometimes another medical illness, for example, having dehydration, metabolic derangements, that kind of thing. Those are the most common reasons, but it could really be any insult to the body.
Okay, thank you for that. Can CAR T cellular therapy be used to treat and stop the damage caused by smoldering MS?
So CAR T stands for chimeric antigen receptor, where T cells are programmed to target a certain antigen. So right now, the CAR T studies in MS involve targeting B cells. So they have targets like CD19, which is on the surface of B cells, very similar to how other medications used for MS work, such as Ocrevus. Now, it is possible these drugs may work better in that they may have a more profound depletion of B cells in different areas of the body, so they could be more effective, but they don't necessarily specifically target what we think is the pathogenesis of smoldering multiple sclerosis. It's not like this targets microglia. So my view would need to have a different type of CAR T therapy that hasn't been yet studied in MS to target microglia, and it's really different from what's being actively researched.
Thank you. Speaking about CAR T, can you please explain the difference between CAR T cellular therapy and stem cell therapy at this time?
So, stem cell therapy is kind of a broad term. So, many people, when they hear the term stem cell therapy, are thinking of the treatment hematopoietic stem cell transplant. In this treatment, chemotherapy drugs are used to wipe out the immune system, and a transfusion of stem cells is used to help regenerate the immune system. But it's actually known that it's the conditioning regimen, the drugs that are given to wipe out the immune system, that are actually driving the effect of the treatment. And so some commonly used drugs would be cyclophosphamide and anti-thymocyte globulin, but many other drugs as well. And it's thought that the stronger the conditioning regimen, the more likely to achieve a long-term remission in terms of multiple sclerosis. So that's not really a stem cell treatment per se, in that it doesn't involve any kind of regenerative stem cells. It's really more of like an immune rebooting type of treatment, but it can be effective and some people can have long-term remission afterwards. There's another idea of using stem cells as a regenerative treatment. You give someone mesenchymal stem cells, maybe you inject it intrathecally into the cerebral spinal fluid, and maybe those cells could differentiate into oligodendrocyte precursor cells or other cells involved in nervous system function and repair damaged tissue. That's a totally different type of treatment, in my personal opinion, unproven at this time, but there's research on this topic.
Thank you. All right. Another subject. First off, there are a lot of people online that have asked how we get Dr. Beaber to their state or their city or et cetera. And I have to tell everybody that you're just a doctor in California, but I want to let you know that you're very well liked from this program. So kudos to you. Okay.
I appreciate that. Thank you to whoever wrote that.
Great. Okay. Next, people want to know, with regard to the smoldering MS, what is the best way that they can stop a smoldering MS, or what do you think is the best things that they should be doing for this?
Well, what I said about the investigational drugs is theoretical. But in terms of what you can do right now, one I should say is there is evidence that currently available disease modifying therapies do have effects on PIRA. They do seem to reduce disability progression independent of relapses. So there is some evidence for existing drugs. They just may not be perfect. And I have many patients who are long-term stable on standard, readily available disease modifying therapies. I wish it was everyone, but it certainly is many people. So that's one element of it. I think the other things that you can do are to have an excellent diet, even though I don't necessarily think there's a single proven diet. I think it could make a difference. I think that it's reasonable to eat a lot of whole fruits and vegetables. There's some evidence that seafood may be beneficial in multiple sclerosis, and avoiding processed food, refined sugars, refined starches, excess sodium that's present in processed food. In terms of vitamin supplements, I think the ones that have the best evidence would be vitamin D supplements. Low vitamin D is linked to MS, and some randomized trials show that vitamin D is beneficial in people with MS. It may be a relatively modest effect. There's also some data on omega-3 supplements, such as fish oil and flaxseed oil. Exercise is important in multiple sclerosis, even though exercise is difficult sometimes for people with MS and may make them feel temporarily worse. There's a lot of evidence that it's good in the long run, and it's different for everyone. Some people may not be able to sustain sustained cardiovascular exercise. So a lot of people have to do short bursts of exercise and then rest. But in the long run, it's going to help you. And as mentioned before, if you're smoking, to quit smoking. And there may be other psychological factors in MS. One of my colleagues, who's been practicing for many decades, told me that she feels her older patients who are doing well, who have a low amount of disability, they often tell her that they sleep well. And so getting adequate sleep may be important in people with MS, and managing stress. A lot of my patients tell me that stress definitely worsens their MS symptoms. So finding a way to cope with and manage stress could be important. That's sort of what we could do right now. And of course, I hope that some or all of the drugs that I mentioned could be proven to be even more effective than what we have right now.
What happens to spinal cord lesions when they've been there for 7 years and then they aren't mentioned anymore? We know that brain lesions can turn into black holes. Does something similar happen to lesions on the cord?
So generally speaking, it can be difficult to recognize that a spinal cord lesion is dark on T1 sequences. The short answer to that question is yes, it can happen, but often MRI scans of the spine look normal on T1 sequences in people with multiple sclerosis. So it can be very difficult to see. MRI of the spine is usually not as technically good as MRI of the brain, just probably because the white and gray matter tracks are very close together, and there can be various artifacts, such as from the beating heart causing a movement artifact and things like that. So sometimes, even if the lesion didn't actually go away, it could be hard to see on a subsequent MRI. So sometimes lesions do completely resolve, but sometimes they can just appear to resolve because it's technically difficult to see that particular lesion. And then it could appear again on the next scan if the quality is a little better.
Great, thank you for that. Next one wants to know if somebody failed, or their body failed, or the drug failed them. What are your thoughts on going on to like a Mavenclad?
Well, Mavenclad or cladribine is one of the medications for MS that's considered to be, highly effective, and it has its own side effects. It is an immunosuppressant medication and can cause other skin problems and things like that. But it's certainly an option for someone who didn't do well on another medication. It would depend on that specific person, what their other medical conditions are, their personal preferences, what other medications they've taken in the past. It's hard to answer that in a general way, but it's certainly one of the medications that's thought to be more effective in MS.
Great, thank you. Next one is, we spoke about community doctors and possibly community doctors in the rural areas, obviously not having the same knowledge to be given to patients as those that are the MS specialists in the urban areas. What about the radiologists? Is there a difference in how one radiologist versus another reads the MRI?
In my opinion, there's a pretty significant difference. I'm lucky to work with some very good neuroradiologists, and the culture at my institution is such that they're the ones who are going to read the overwhelming majority of those, films. My experience is that sometimes radiologists will make sort of generic comments about MRI scans, like there are several non-specific subcortical white matter lesions that could be related to migraine, vasculitis, multiple sclerosis, or other causes, and things that aren't helpful. So yeah, I would say there's a lot of variation in the quality of radiologists as well.
Great, thank you. What are the most common side effects of multiple sclerosis, most common symptoms that you can speak about, please?
Some of the most common symptoms would be fatigue, having optic neuritis or pain and vision loss in one eye, having numbness and weakness of the limbs, or having symptoms like double vision and vertigo. Some people with MS have neuropathic pain, burning, or sharp pain in different areas of the body. And sometimes people can have subtle cognitive symptoms, especially in terms of having problems with processing speed or multitasking. And really, anything the central nervous system does could be a symptom of MS. So there are many others I didn't mention.
Thank you. If somebody starts using a DMT later in life, like around 47 or 50 years old, is there the same amount of potential worsening or non-worsening as though if they never got onto one?
Well, there's sort of more evidence for disease modifying therapies in people who have more active inflammation. And so there may be a greater benefit of taking disease modifying therapy in a young person with very active multiple sclerosis with a lot of enhancing lesions on MRI scans. But every person is different. I have some younger patients who unfortunately do have progressive MS and don't have a lot of active inflammation. I have older patients who have relapses and have made active lesions, even if they're over 60 years old. So it's really an individual thing. But overall, I would say there's more proof that our medications are most effective in younger people with relapsing MS.
Okay, thank you. All right, so a person wrote that they have lived with spasticity for a very long time, and they were recently told that they should go to one of these stretching programs. What do you recommend about these stretching programs, and how could it be positive or negative for them?
Yeah, spasticity can be a significant symptom in MS, and stretching is one of the treatments that's effective. In terms of a specific stretching program like Stretch Lab, that type of thing, I don't have a lot of experience with it. I have had a few patients tell me they found it to be effective, but really stretching is something you're going to have to do all the time. You're going to have to do it as a daily basis for it to really work for you, I think.
Okay, thank you. Next, we're running down on questions now, which is a great thing. All right. Will reduction of microglial activity eventually lead to demyelination? Is that the ultimate goal?
Well, it's thought that the microglia are doing something other than demyelination. And so the microglia may be damaging the local tissues in kind of a non-specific way, not just the myelin, maybe damaging the axons and other supportive elements in the central nervous system. The thing about the adaptive immune system, the B and T cells, is they're recognizing a specific target. And in MS, that target is antigens in the myelin. For instance, it could be recognizing myelin basic protein, a protein that's part of the myelin. But with microglia, it may not be recognizing anything specific at all. It's just damaging the region in general. So it's becoming not just a demyelinating injury, but sort of a general inflammatory central nervous system injury, which is why we need a different type of treatment.
I would like to know, a person's writing, I would like to know more why disability progresses even though one can be on a DMT.
Well, I gave a list of different possibilities. One possibility is smoldering multiple sclerosis, which is inflammation that's driven by immune cells not affected by those disease-modifying therapies. But I think other mechanisms are possible, like oxidative injury and mitochondrial failure within the actual neurons. I don't necessarily think it's the same thing in every person, but hopefully it's something that we can treat. I think if it was due to these microglia and we could come up with new treatments that would target those microglia, that's a very optimistic view of the world. And maybe our treatment of progressive MS could get better and better over time.
Okay, great. Thank you for that. All right. We have just 4 questions remaining. What are the thoughts of use of a vibration plate?
So vibration plates are these little plates that you stand on that vibrate under you, and they're mostly used to treat conditions like osteoporosis, and they basically stimulate the bones and cause bone growth. I think there's a lot of evidence in the use of treatment of that condition, but some people use vibration plates just for general exercise and recirculating, pooled blood and lymph and things like that. And I think it could be effective. I'm not aware of, specific research in MS, but I think it could work for someone.
Can you speak about the benefits of participating in research and how can we learn about research opportunities?
So, a good place to find an MS clinical trial would be to go to the National MS Society website, and they have a list of clinical trials. If you are being seen in an academic institution, of course, you could ask your neurologist if they're doing any trials. But of course, there are many, many trials going on, so the one you're interested in may not be done there. Another thing you could do if you're in the United States is go to the website clinicaltrials.gov. And on that website, you can type in multiple sclerosis and your location, and you can even put in other parameters, such as, is it an interventional trial with a drug? And find sites of trials that are near you and see if there's one that suits your interest. And there are all kinds of different trials. Some are non-interventional trials. They're observational studies. For instance, you could study, do these PET scan findings actually correlate with future development of disability? But you could enter an interventional randomized trial for a drug, and there are different phases. Some are early trials for maybe a drug like firalimab that's not yet being studied in randomized trials where everyone gets the drug. Or it could be later phase trials where there's actually randomization comparing the drug being studied versus either another medication or a placebo. And not everyone is really comfortable entering a clinical trial. It often involves a lot of doctor visits, a lot of evaluations. It can be a big hassle if you're a busy person. You may be receiving a medication that we don't know if it's effective or safe yet. And of course, you may be randomized to the placebo group, and some people don't want to be randomized to the placebo group and are just not comfortable with that, which I certainly understand. But I really do appreciate people who do enter clinical trials. That's really the only way we get new information about people with MS and how to best help them. And ideally, you would enter a trial, get a new investigational drug, do very well on it. But even if you didn't have that experience, even if the drug didn't work for you, or you got the placebo group, or the drug was ineffective, you're still contributing to MS research and making life better for future people, future generations of people with MS. So I really appreciate it. I know the MS community in general really appreciates it.
Great, thank you. I have a question for you. When is it too late When would it be too, why would a person have to stop driving? A person with MS.
So, neurologists frequently send notices called confidential morbidity reports to the DMV for conditions like epilepsy and dementia. And we're actually required to send these. For multiple sclerosis, the concern is often weakness of the legs and difficulty using the pedals. And it's very subjective and difficult to judge, but if I have a patient tell me I feel unsafe, like it takes me a long time to move to the brake, I would have reservation about that. But it's difficult for me to give advice on that. One thing is, if you are in that situation, your legs are too weak to reliably control the pedals, California DMV does have a program where they will actually train you to use hand controls. And so I have a few patients who have retained driving ability, even if their legs are too weak to control the pedals. So that is an option for people.
Person wants to know if, number one, you know about conversion disorder, and if a person with conversion disorder, is it possible for them to develop multiple sclerosis?
So, conversion disorder refers to a class of conditions where a physical symptom may be the result of something like psychological stress. For example, someone could have what's called a non epileptic seizure, where they're having convulsions, but they're not actually having an epileptic seizure, which is caused by the spread of electrical activity over the surface of the brain. And we don't exactly fully understand why this could occur. Sometimes it occurs for an obvious reason. Someone has severe depression or they've had some obvious stress like a death in the family. But sometimes it happens for very unclear reasons and it's poorly understood. And you can have a conversion disorder causing any symptom. There are some people who may have other symptoms throughout the body that have nothing to do with neurology that are also conversion disorders. And it's not specifically associated with multiple sclerosis, though it's certainly possible to have two things. You could have multiple sclerosis, but also a non-epileptic seizure due to conversion disorder. And I have seen that from time to time, but there's not necessarily a specific correlation.
Thank you. One of the last remaining questions is that, and this comes up in several programs during the course of the year. What do you know about CCSVI and what are your thoughts?
So CCSVI stands for chronic cerebrospinal venous insufficiency. And there was an Italian vascular surgeon named Paolo Zamboni who was studying multiple sclerosis because his mother has multiple sclerosis. And it's been well known for many decades that the lesions in MS, as I mentioned earlier, occur around the veins. So he had the idea that maybe the problem isn't the immune system, it's actually something wrong with the veins. And so he started doing ultrasound studies, and he found that many people with MS had abnormalities in the veins of the neck and in the chest. And he thought that that was the real cause of multiple sclerosis. And so people in the late 2000s and early 2010s were actually having procedures such as a balloon angioplasty of the veins or stents placed to try to treat multiple sclerosis. And some people reported anecdotally that it was helpful to them. And subsequently, there have been clinical trials. For instance, there was a clinical trial called the Brave Dreams trial, which did not show that there was any benefit to getting this procedure, this intervention, the angioplasty, versus just getting a sham or fake procedure. So it's really an unproven treatment, and it's really unknown if the veins have anything to do with multiple sclerosis.
Did everybody enjoy today's program? Clap. Great, awesome. And that's it. We're going to call it a wrap. And Dr. Beaber, thank you so much for spending the time to be here with us today. And again, lots of kudos coming in from online. And have a great day, everybody. I'm saying ta-ta. My voice is done.
Thank you for having me.